We are at CRT 2014. A reminder that the abstracts for this meeting are in JAC Interventions, so please check that for the abstracts. But for right now, I want to talk about the CRT presentations here covering how the various antiplatelet agents fit into the management of patients with ACS. And this is a great topic and a great time to be talking about it. I'm with Dr. Paul Gerber, who is director of the Sinai Center for Thrombotic Research and the Sinai Hospital of Baltimore in Maryland. We've had so many papers come out recently that are questioning just exactly how long we need to be taking antiplatelet therapy for patients who have ACS. First off, what are you presenting here specifically, and any guidance in terms of how to respond to some of these new trials?
Well, the work that most of the talks I'm giving here are centering around personalization of antiplatelet therapy, which may indirectly answer your question about duration of antiplatelet therapy. But the thrust of the work in our laboratory at Sinai Hospital has been on identifying patients who are non-responsive to antiplatelet therapy and then changing their therapy to a drug that provides a predictable pharmacodynamic response. So many of the lectures here have centered around the whole utility of personalization, which candidates may be the best to do personalized therapy. How do you personalize? Do you do it with platelet function testing? Do you do it with genetic testing? Right. So that's in large part what I've been discussing. In part, measuring thrombogenicity of the patient on dual antiplatelet therapy may give us an idea of whether or not a patient should stay on the dual antiplatelet therapy or come off. So for example, if I had a patient who had stents implanted, who had a thrombogenic profile that was in the highest quartile, who has complex disease, I may be reluctant to stop the dual antiplatelet therapy at 6 months or 12 months. We really don't have the information in this area. Of course, we know that there is a large-scale clinical trial that's going to involve many thousands of patients that hopefully will get us toward an answer. But what I always tell interventional cardiologists is that I've never seen a platelet wear a wristwatch. They can't tell time, and they don't know when their reactivity is high or when it's low, and they don't know when to turn off their responsiveness to agonists. So I think we have not done a good job in studying platelet reactivity serially and determining whether the patients with the highest platelet reactivity, who are the most thrombogenic, stand to lose the most when they come off of the antiplatelet therapy. We just now stop it based on time, which physiologically is somewhat relevant because we know that platelet reactivity falls over time, but there are patients who harbor active platelets, reactive platelets in their circulation, who may be at increased risk when you pull them off of a P2Y12 inhibitor.
What specific advice do you give when you're talking to a room full of cardiologists and interventionalists?
I tell them to follow the guidelines, and I tell them that in general, look at each patient individually, look at their demographic variables, look at whether they've had prior thrombotic events, look at the complexity of their anatomy, how many stents have been implanted, how long are the stents, are they bifurcation stents. These may be the patients that I would be more reluctant to pull off of dual antiplatelet therapy, certainly at 6 months, maybe even at 12 months. And maybe we could support those demographic variables with findings, objective laboratory findings of high platelet reactivity, robust thrombin generation, high platelet fiber and clot strength. These would be the patients I'd be particularly reluctant to pulling off of dual antiplatelet therapy at 12 months. And at our center at Sinai Hospital, in my laboratory, when I get patients referred to me directly related to this question of duration of antiplatelet therapy, we study their blood in our laboratory to determine, based on, in comparison to our data set, where these patients reside with regards to indicators of how prothrombotic they are. And if they're prothrombotic, if they have complex anatomy, if they have complex demographics, all that would be associated with a high thrombotic risk in general, and if they have a low bleeding risk, or an acceptable bleeding risk, perceived bleeding risk, we keep them on dual antiplatelet therapy beyond 12 months.
And on the other side, who would you feel comfortable pulling it a little early for whatever reason?
Well, I think the first important point is that the studies that have looked at early discontinuation, early stopping of the antiplatelet DAPT per protocol have all been underpowered. So we've been very...
That's a tough question, that is.
So we don't have the answer. The studies have been underpowered, undersized, and so what I would say right now is follow the guidelines. I'm very hesitant to stopping dual antiplatelet therapy before 12 months with a drug-eluting stent. If there are certain circumstances where the patient may need a surgical procedure, there are considerations where we would stop it earlier. But in general, we don't have the adequately sized clinical trials that tell us it's safe.
And finally, anything in regards to bridging that you've learned in the last few years with some of the new agents?
Well, bridging is something that we've done with parenteral small molecule 2B3A inhibitors. But again, if you look in the literature for clinical data to support that, there are no prospective data, no convincing data. It makes sense to do it, but there just are no trials to support it.
Still a lot of work to be done, clearly.
There's so much more we don't know than we know. So that's true.
Absolutely. And what you do know is that we have a lot of coverage from the CRT 2014 meeting. Please go to CardioSource World News for additional information. I'm Executive Editor Rick McGuire.